Clinical practice defines premature ejaculation through a metric called IELT. It represents an involuntary failure of reflex control, where neurological tension suddenly snaps. Treatment involves selective serotonin reuptake inhibitors, or SSRIs. This class of drugs is traditionally used to manage chronic, systemic psychiatric conditions. Standard SSRIs require weeks of continuous daily dosing to build a steady-state plasma concentration in the bloodstream before providing a clinical effect. Dapoxetine is chemically classified as an SSRI, yet it is utilized as an acute urological intervention rather than a tool for daily psychiatric care. This graph illustrates the contrast. On the left, a traditional SSRI builds concentration over weeks. On the right, a single dose of dapoxetine creates an isolated spike in plasma levels. This sharp deviation from the standard SSRI profile allows dapoxetine to function as a rapid-acting treatment for an acute reflex. When administered correctly, this rapid chemical action provides a 3 to 9-fold multiplier to a patient's baseline latency time. This rapid neurological modulation triggers hemodynamic side effects that require strict clinical management. Dapoxetine serves as a precise clinical tool that demands rigid prescribing limits to balance its latency-extending effects against systemic organ strain. The ejaculatory reflex is triggered when physical excitement reaches a specific threshold in the central nervous system. Dapoxetine inhibits serotonin reuptake in the synaptic cleft. By increasing active serotonin, the drug raises the reflex threshold and dampens the urge to discharge. Blocking those synapses at a specific moment requires a precise pharmacokinetic profile, tracking how the drug travels through the body. This curve maps initial absorption. Following oral ingestion, plasma concentration spikes between hours 1 and 2. This maximum concentration, or Tmax, occurs in this window, defining peak efficacy. The concentration then drops precipitously as the chemical is rapidly cleared from the bloodstream. Because of this rapid clearance, Dapoxetine does not provide the steady-state protection required for a daily prophylactic treatment. Its chemical profile restricts it to an on-demand, carefully timed intervention. Dapoxetine acts immediately on the target reflex because of its aggressive absorption and clearance, rather than lingering in the nervous system. Clinical trials in the UK and US provide the primary data for the results generated by this absorption spike. Participants in these trials recorded an unmedicated baseline IELT of 1 to 1.5 minutes. Following administration, the data proves a 3-fold latency extension, with active duration advancing to 7 to 9 minutes. These 7 to 9 minute durations are achieved through a single acute dose. This high-impact chemical action creates a measurable biological cost in the form of systemic organ burden. Clearing the drug taxes the renal pathways, putting sudden strain on the kidneys. To manage this strain, the clinical limit is set at 1 tablet per 24 hours and a maximum of 3 to 4 doses per month. While clinical data shows performance gains, the drug's utility is restricted by the kidney's mechanical ability to clear the chemical safely. Beyond renal considerations, dapoxetine triggers systemic vasodilation. Sudden vasodilation causes orthostatic hypotension, a rapid drop in blood pressure that reduces circulation to the brain. This drop leads to a cascade of symptoms, including dizziness, presyncope, or total fainting. Safe administration requires taking the medication with a full glass of water to support blood volume. If dizziness occurs, the immediate protocol is to lie down and elevate the legs to quickly restore cerebral perfusion. Concurrent use with cardiovascular or blood pressure medications is prohibited due to this hemodynamic volatility. Combining dapoxetine with other neurological drugs like fluoxetine or paroxetine can also lead to severe serotonergic side effects. The potential for cardiovascular shock necessitates strict physiological management for every dose. Clinical oversight must also address the misconception that the drug follows a linear dose response. It is a mistake to assume that if 30 milligrams provides a 5-minute extension, 60 milligrams will yield 10 minutes. This graph shows that as dosage moves towards 60 milligrams, the efficacy line hits a plateau. Moving beyond an effective 30 milligram dose results in negligible improvements to ejaculatory timing. While timing improvements flatline, the risk of adverse hemodynamic events spikes exponentially at the 60 milligram mark. For initial responders, 30 milligrams is the maximum safe dose. The 60 mg dose is reserved exclusively for patients who show no clinical response to the 30 mg baseline. With Dapoxetine, higher doses fail to improve urological timing. They primarily increase the risk of systemic toxicity. The data forms a complete pharmacological model of Dapoxetine's action. It is a rapid-acting neuromodulator that provides a high multiplier latency extension. These results are inextricably linked to blood pressure volatility and acute renal taxation. This matrix summarizes the rules for safe navigation: timing the 1 to 2 hour lead time, adhering to the 30 mg limit, and restricting use to 3 or 4 times per month. Following these pharmacokinetic limits is the only way to achieve the 3 to 9-fold latency multiplier safely. Evaluating a patient's systemic health before administration requires a urologist or andrologist. Using this powerful, volatile SSRI as a daily lifestyle supplement is a serious medical error. Dapoxetine is a high-impact clinical tool that requires precise diagnostic discipline to navigate its rapid-acting mechanism.